All right, welcome to this explainer. I am going to be your clinical tutor today, and I am absolutely thrilled to welcome you to your very first virtual dermatology ward round. Now, it is incredibly easy to look at a complicated rash or an angry skin lesion, panic just a little bit, and then try to just guess the diagnosis. But we are definitely not going to do that today. Instead, we're going to learn a foolproof, step-by-step observational framework for diagnosing skin lesions. This is drawn straight from the brilliant methodology of dermatologist Richard Ashton and Barbara Leopard. And I promise you, by the end of this session, you're going to have the tools to analyze literally any skin problem like an absolute pro.
Okay, let's dive into this. Here's a super quick look at our roadmap for today's ward round. We've got 6 sections. 1, taking the patient history. 2, conducting the physical exam. 3, defining the lesion types. 4, analyzing surface and border. 5, color and consistency. And finally, 6, making the differential diagnosis.
Section 1, taking the patient history. Before we even think about laying a hand on the patient, we really need to ask the right questions to set the stage. Now, it might seem incredibly basic, but the absolute most important question you can ask in dermatology is simply this: how long has the lesion been present? We have to immediately figure out if we're dealing with acute lesions, meaning they've been present for less than 2 weeks, or chronic lesions, which have been hanging around for more than 2 weeks. Honestly, this single little detail instantly cuts your differential diagnosis right in half.
So here is your essential go-to checklist for the patient history. We already talked about duration, but right after that, you want to ask if the lesions come and go. For instance, if a patient tells you their rash appears and completely vanishes within a 24-hour window, maybe even changing shape and moving to a totally different site, that instantly points us straight toward urticaria. Next, check for any relationship to physical agents, sun exposure or harsh irritants. Then, is there itching? If a patient complains of severe itching, especially at night when it's literally keeping them awake, well, scabies should jump right to the very top of your mind. Finally, you just round out the history. Ask about any past similar rashes, family history of skin issues, their social history, and crucially, what previous treatments or random ointments they've already tried putting on it.
When you're asking about sun exposure, you need to establish their skin response using the 6 recognized skin types. Type 1 skin always burns and never tans, right? Whereas type 4 rarely burns and tans really well. Documenting this is absolutely vital because patients with those fairer skin types, types 1 and 2, are just much more liable to develop skin cancers. Also, be sure to ask about the time interval. Does the rash pop up 5 minutes after they go in the sun, or does it take several hours? That little detail actually tells us a ton about the underlying photodermatosis. All right, section 2. Conducting the physical exam. It is time to step right up to our virtual patient.
Okay, so the absolute golden rule here is that we never, ever just glance and guess. We follow this rigorous 3-step sequence every single time. Look, feel, and describe. First up, you rigorously look. Observe the site, the number of lesions, check if they're symmetrical or asymmetrical, and see how they're arranged. Then you actually feel it. Run your fingertips over it for surface palpation and do a deep palpation between your finger and thumb to really gauge the thickness. Finally, you describe it, and you do that based on its type, surface texture, color, and border.
Section 3. Defining the lesion types. Let's just hit pause on the exam for a second because to properly describe a rash, we all need to be speaking the exact same language. Now, what's genuinely brilliant about these categories is how neatly they organize the chaos. Pretty much every single skin lesion fits perfectly into one of these 4 broad buckets. A lesion is either flat, meaning if you close your eyes, you can even feel it; raised, meaning it's a solid, elevated bump; fluid-filled, which means it contains clear serum or pus; or it has a broken surface, meaning there's actual physical loss of the epidermis or dermis. Let's clearly contrast these crucial terms, mostly because students tend to mix them up all the time. A macule is totally flat and less than 1 centimeter across. Think of a standard freckle. A papule is also under a centimeter, but it's a raised, solid little bump. Now pay attention to nodules and plaques. They are both over a centimeter, but the big difference is in the geometry. A nodule has real thickness and depth to it. You can really palpate it between your finger and thumb. A plaque, on the other hand, is wide and flat-topped. Its diameter is just much, much greater than its thickness. Section 4, analyzing surface and border. Let's move in a little closer to our patient to inspect the intricate details of the lesion's surface and the edges where it meets the normal skin. The surface texture is just incredibly revealing.
If the surface is totally smooth and normal, like it feels exactly like the surrounding skin, the pathology is usually hiding deep down in the dermis. But if you encounter an abnormal surface, something scaly, crusty, or maybe with warty projections, that tells you immediately that the epidermis is affected. Now, two surface features that are constantly confused are scale and crust. Let's set the record straight on this one. Scale is dry and flaky. It's a buildup of shedding keratinocytes from an abnormal stratum corneum. You see this all the time in psoriasis. Crust, however, is dried exudate. We're talking dried serum, blood, or pus. Think of discoid eczema for that one. And here's a massive clinical pro tip for you. To find the actual cause of a crust, you should try to gently pick it off. Picking it off is going to reveal the real damage underneath, which is usually either an erosion or an ulcer. The way a lesion actually meets the normal skin brilliantly illustrates the importance of edges. Is it well-defined? Like, could you literally take a pen and easily draw a perfect, crisp line right around it, like you can with psoriasis? Or is it poorly defined, sort of gradually merging into the surrounding skin, which is super classic for eczema? Or maybe it has an accentuated edge. That's a pronounced border with some relative clearing right in the center, very characteristic of ringworm. You see, defining the border dramatically shifts our differential diagnosis. Section 5, color and consistency. It's time to actually physically touch the lesion again and combine what we're feeling with what we're seeing. When you do a deep palpation, literally squeezing the lesion between your thumb and index finger, you need to grade its consistency. And I've got a fantastic tactile anchor for you here. Go ahead and just feel your own face for a second. If a lesion is soft and really easily compressible, it should feel pretty much like touching your lips. Think of a skin tag for that. If it's firm and only slightly compressible, it's going to feel a lot like touching the tip of your nose. A classic example there is a keloid scar. And if it's somewhere in the middle, it's just normal consistency, kind of like a lipoma. Next up, we check the color, which honestly gives us massive clues about the underlying pathology. Brown or black is usually melanin, yellow heavily suggests lipid deposition, white usually means depigmentation. But let me ask you a quick question. Why do we care so much if a red or pink rash blanches, meaning it temporarily turns white when we apply pressure to it? Well, because if it blanches, that means the blood is still inside the dilated blood vessels. That's erythema. But if it doesn't blanch, the blood is actually leaked out into the surrounding tissues, meaning we are now dealing with purpura. Big difference. Section 6. Making the differential diagnosis. This is the big payoff, folks. Let's see how all these slightly disjointed vocabulary words we just learned lock together into a single, incredibly powerful diagnostic tool. Right here is your ultimate 7-step descriptive algorithm. Whenever you face a patient, you just run through this checklist. Record the site, check if it's erythematous or not, note if it's acute or chronic, describe the exact surface features, determine the specific lesion type, examine that border, and finally note the color. Gathering these 7 specific data points will literally lead you directly to the correct diagnostic algorithm in your textbook, every single time. Let's actually practice this. Okay, imagine a patient walks into your clinic. You start following the steps. Step 1, you note the site is the face. Step 2, it is completely non-erythematous, 0 redness. Step 3, the patient tells you it's been there for several months, so it's chronic. Step 4, you touch it and the surface feels completely normal and smooth. Step 5, because you can't feel it at all with your eyes closed, it's a flat patch. Step 6, the border is incredibly sharp and well-defined. And Step 7, the color is pure, stark white. So, looking at all that, what's your diagnosis? The diagnosis is vitiligo. See how perfectly our 7-step observation mapped straight to the answer? There was absolutely no panicking, no guessing required. Just systematic, cool-headed observation of a chronic, flat, well-defined white patch with a completely normal surface. Let's move to another one and see how this builds with one more rapid-fire example. Ready? Step 1, the rash is located on the trunk. Step 2, it is bright red, so it's clearly erythematous. Step 3, it's been there for weeks, so we're calling it chronic. Step 4, you rub a finger over it and the surface is super dry and scaly. Step 5, they're small, raised, solid little bumps under 1 centimeter, so that makes them tapules. Step 6, the border is very well defined. Do you know what it is? It's gut tape psoriasis. I love this because it proves that by replacing pure guesswork with structured, clinical observation, you can identify essentially anything that walks through your door. You just need to remember to look, feel, and accurately describe. We're going to wrap up this explainer with a really empowering quote from dermatologist Richard Ashton and Barbara Leopard. They wrote, "However much or little you know about skin disease, you can always arrive at the right diagnosis. The secret is to examine the surface, which will help you classify the clinical features correctly." By following the steps we outlined today, you now have a literal roadmap to diagnostic clarity. So I'll leave you with this final thought. The very next time you come face to face with a totally unknown, confusing rash, are you going to guess or are you going to observe?